Okay. Hi, everybody. Hello, and welcome to the Enhanced Breast Cancer Detection webinar. My name is Brooke Incontrera, and I'll be today's moderator. Thank you for joining us for our first live event of our ebcd program. Please note this webinar will be recorded, and a link to the recording will be emailed out to registrants within the next few days. You will also receive an email with instructions on how to pull your CME credit within a day or two. Attendees will be muted, but we encourage participants to submit questions via the chat window in the Zoom platform. These questions will be addressed at the end of the presentation, time permitting. Before the presentation begins, I would like to introduce our panel of presenters. Our first presenter today will be Dr. Greg Sorensen. Dr. Sorensen is a neuroradiologist and former professor at Harvard Medical School. He is also the founder and president of Deep Health, RadNet's AI division, which developed the software behind the ebcd program. Our next presenter, Dr. Jacqueline Holt, is the medical director of women's health at Delaware Imaging Network. And last, but certainly not least, we have Dr. Renee Quarterman, the medical director at Delaware Breast Care. And now we will have Dr. Greg Sorensen kick us off.
Thanks so much, Brooke. Great to be with you this afternoon. It's my pleasure to talk with you about enhanced breast cancer detection. We're going to divide this up into me talking about the artificial intelligence, reviewing with you some of the science behind AI, and specifically around the new AI that's so powerful for helping the performance of mammography. Then I will pass it, as you've heard, to our next panelist, Dr. Holt, who will provide some clinical context from a mammographer's perspective. And then, of course, Dr. Quarterman to give you the patient caregiver direct experience. So let me dive right in and talk with you about AI. I think I'll lay the foundation, and then we'll build on that all the way to the patient benefit. It's impossible to turn on your phone or your TV or anything these days without hearing about artificial intelligence. It seems everywhere. And you might be asking, well, okay, I've heard about ChatGPT. I know Google Images Google Photos can find things in my phone. What's really going on here? Why this breakthrough in artificial intelligence? And it actually helps to understand just a little bit of the math, because that will help you understand why we can do certain things well and we can't do other things well with modern AI. Just like ChatGPT can do some things well, but it really messes up on other things. Specifically in mammography, our goal is to analyze pictures, to look at these images. And that used to be a very difficult task, and now it's not so difficult. And the reasons are actually quite interesting. It turns out that the equations underneath both ChatGPT and the math that we use to analyze these mammograms was actually initially developed on paper in the 1940s and first put into computer models in the 1950s. So no patents here. This is all really old stuff, or at least no key patents. And yet it didn't work. It didn't work for decades. But now it does. And essentially what these formulas were our attempt as humans to write down on mathematical equations what we think neurons are doing. Basically, neurons take a bunch of inputs through their dendrites, and then they send down a signal and they fire yes or no. They either depolarize or they don't. So you go from taking a lot of inputs to a single output. And those equations are what is in all of the modern AI. And like our neurons, these equations can be trained to understand pretty much anything we've thrown at it so far if you have enough training data. If you want to show it 1,000 dogs and 1,000 cats, these mathematical equations or software instantiations of those mathematical equations can distinguish dogs from cats. Now, how do we know that? Well, I'm a computer science geek, and for a long time, we computer science guys would get together every year and show off how good is our image recognition. And this is the way we actually used to measure it in the field, is we would have a bunch of pictures, and then your job was to label what was in those pictures. And the different academic groups would get together and hold context to see how good is this year's model. This is an example of the kinds of things and the pictures that you were supposed to be able to find. Is there a bus in this picture? Is there a dog? Where is it? So was it there, and where is it located? And actually, every year there was kind of a bake-off, if you will. They're called the ImageNet Large Scale Visual Recognition Challenge, and groups would get together. And back in 2010, you can see on the left here, the error rate for the top 5 scoring of the hundreds of entrants was about 25%. That is to say, it got the images, it got about 75% of them right, and it missed about 25%. And you can see that things have gotten better and better. And in particular, in 2012, AlexNet was released. This was the first deep learning, so-called deep learning AI tool. And when that happened, you could see there was a dramatic improvement. And since then, it's gotten better and better. And in fact, it's now better than we humans are. If you've ever messed up on one of those web things that has to prove you're not a robot, the CAPTCHAs, we're not perfect at it. The computers are actually better at it, at these kinds of pattern recognition tasks than we are at many, many visual tasks. And you might say, well, why is that? If it's the same equations and people have been working on it, for instance, the 50s, 60s, 70s, what's changed? There's really 3 big things that have changed. We have much more powerful computers, especially with a lot of memory, so we can hold equations that are very large. So these are linear algebra. They're basically, mx plus y equals b kind of things. But instead of a few variables with a few coefficients, there are literally thousands, millions, or in ChatGPT, hundreds of billions of variables, each with a coefficient in front of it. So you need a lot of RAM to hold all those big equations. Second, we can iterate on those equations very quickly because of GPUs that are super fast at doing computing, playing video games as well, but they're really good at computing. And now we have lots and lots of training data. For ChatGPT, it's the whole internet of text. For mammography, it's digital images. We didn't used to have digital mammograms. We only had film, so it was very hard to train those. Now we've got lots and lots of data. And that combination of powerful computers, very high-speed compute, and more data, that's what's led to these breakthroughs. Now, there's all kinds of things you can do with these training data sets. And I like to show this slide because it's a little bit of humorous. This paper was one of my favorites. This group tried to train a system to recognize benign breast biopsy samples versus malignant breast biopsy samples. And their system worked really well, but it turned out the system they were training was actually a flock of pigeons. They actually managed to train pigeons to peck one side or the other when it was breast cancer, malignant, or benign. And they got a really high score, especially if you use the whole flock. It turns out pigeons work really well in the flock. So I like this because it kind of reminds us the goal here is pattern recognition, but there's a lot of ways to recognize patterns. We humans are good at it. Lots of animals are good at it. The question is, can it scale and how good can it really get? That's where the fun comes in AI. So lots of work has gone into many medical AIs. There are literally hundreds of products now FDA cleared that analyze medical images and provide some kind of AI-driven or deep learning-driven output. I've listed 7 mammography products on this slide, all FDA cleared, all AI-based, as opposed to the older, I would say like pre-2015 traditional CAD kinds of AI, tools, which were also claimed, by the way, to be based on neural networks, but they just didn't perform nearly as well as the modern generation. And I want to dive deeply into the one that powers ebcd because it's got some unique features, and that's SageDX. One of the things that SageDX says that's unique is it helps the doctor interpret it quickly by simplifying the outputs. Most AI tools, most AI equations put out an answer between 0 and 100. We've bucketed those into 4 categories. I've listed them here, but we kind of think of them as red, orange, yellow, green, kind of the most risky to the least risky based on an intended population of screening mammograms. We also put a bounding box on where the abnormality is and label that bounding box with how suspicious it is. And then we tell the doctor how suspicious the case is overall. This is what it looks like. You basically get a mammogram and these boxes show up and they've got little labels underneath that say high, medium, and low. And actually up here in the corner, you've got the radiologist gets a case level suspicion, which is just whichever the highest box is on that case. Why did we pick these levels and how do they work and where did we come up with them? To help you understand those categories, imagine that you are Dr. Holt, our next speaker, and your job is to read 5,000 mammograms. There's actually 5,000 dots here. And her job is to try to understand where are the expected number of cancers. We don't know exactly how many there are, but statistically, there would typically be 25. We don't know where they are. They don't jump out like X's like this. So where does the AI come in? What the AI does is it looks at every single one of those dots and it puts it into one of 4 categories. Those 4 categories make sense once you sort. When you sort, you'll see that we've picked the reds to just be the top 5% and the greens to be the bottom 25%. And you can also see where the cancers fall. 87+% of the cancers in this data set that we showed to the FDA that was prospectively collected by and reviewed by a third party, 87+% were in the reds, none were in the greens, and very few were in the orange or the yellow. Now, we can't say, because mammography is not perfect, that eventually there won't be at least one cancer in the greens out of a big number. Here, I've listed it's 1 out of about 4,500 statistically. That's about the same rate of breast cancer as men get. So it's essentially not 0, because some men do get breast cancer, but it's so low that you would not screen or recall a patient typically with this kind of a score. So that's how we've created these scores. And the goal was not just to have the AI work, but to have the AI work in a way that we physicians can consume it effectively. And then we had to demonstrate that we've done that. And I'm going to show you 2 sets of scientific studies, maybe 3, that we think demonstrates really well that this AI really does improve the care for women. When we asked the FDA for approval to market this product, to bring it onto the market, they asked us to compare how physicians read mammograms, how well they did at reading mammograms without the AI and with the AI. And they were interested in particular about generalists and specialists. You may not know this, but across the United States, about 80% of mammograms are read by generalists. And so on the left are 9 generalist radiologists, so not full-time breast imagers. And on the right, the circles, those are 9, more than 75% of their time doing breast imaging specialists. And in the middle, you can see with the error bars, the average performance of the specialists and the generalists. Here's the specialists in the circle and generalists on the square. And you can see there's a difference. We physicians know that if you do something a lot, you get better at it. And no surprise, we also saw this task, which was find the cancers versus the non-cancers in 240 mammograms. There were 100 cancers in there. Guess what? The specialists do better. What's interesting is when you add the AI. When you add the AI, what you see is that all the doctors get better. SageDX is the only AI tool that's demonstrated that in these very rigorous reader studies that all the doctors get better. But what I find particularly interesting is the generalists get better than the specialists without AI, and statistically just about as good as the specialists with AI. And you can see that some of the specialists are getting very good accuracy here. This X is actually where the standalone performance of the AI is just on its own. And what we were particularly pleased to see here is that this improvement was present for all races, all age groups, all different breast densities. Every mammogram benefited from the presence of the AI. And so that's very powerful evidence. And that's been reviewed by the FDA. It's in our FDA label, and happy to review that if there are questions afterwards. Now, I wanted to also show you that since we've developed this AI, we've been testing it and checking its performance. And just a couple of weeks ago at the Society of Breast Imaging meeting in Maryland, we presented some data that was a part of a peer-reviewed abstract. And I just wanted to share with you a few highlights of this data because I think it's quite compelling real-world evidence. We rolled out the AI in the background without the physicians knowing and just ran it prospectively for a period of about a year while the physicians were just reading away without access to the AI. And then we looked at the biopsies of all of those mammograms with about a year's follow-up. And this data, I think, is very compelling because it is prospective. We decided to do this in advance, 148 clinics. It turned out to be a large data set, over 570,000 mammograms over the course of this year. It's unenriched, So we didn't somehow select out something. It's every single mammogram that was available and that the AI could run on. We ran on it. And of course, it was longitudinal. So we got all the biopsy outcomes with a year-long follow-up. So we pretty solid real-world data. What did we learn from this? How do these categories work? How is the AI? Are these categories good categories? Well, this is before the docs get the AI. Let's just look at how the AI worked on this data set. Well, as you might expect, the cases that were ranked red had a lot of cancers in it. And in fact, you can see just by the stats here that the cancer detection, so we know that the typical rate of cancer in the population is 5 per 1,000, and that's what the intermediates were, the intermediate cases. The high, those reds, 82 cancers per 1,000. So a very, very high likelihood of cancer in the reds. And you can see the suspicion level. This is about 15 times higher than in the general population. The intermediates are kind of general risk or similar, and the minimal 25 times lower risk than the general population. So that's exactly doing what we were hoping it would do. These categories look very compelling. And you can see from data like this that while there's not zero cancers in the greens, because there's always interval cancers, mammography is not perfect, if it's green or yellow, there's a very, very, very scant chance that there's a mammogram there. Now, what about recall rate? Did recall rates go up? What we learned is that our doctors across 148 clinics are recalling even the greens too much. And that tells us the AI should be able to help doctors not just improve sensitivity, but improve specificity. Look at, we know that the Institute of Medicine says an ideal recall rate overall in general should be between 5 and 12. And of course, you'd like there to be a lot of recalls in the reds and the oranges, but you'd like there to be very few, ideally kind of a low number, like 1 or 2 per 1,000%, if even that, because you saw, if you go back and look at these stats here, right, there's only 0.16 per 1,000. So the positive predictive value of this recall is not very high, and even at 5.7%. And so this goes, the cancer detection rate goes up exponentially, the recall rate goes up linearly. And if you plot that, what you see is the positive predictive value is much higher for the reds than it is for these lower scores. And in fact, when you compare this to what the national guidelines say, basically nobody likes a PPV under 3. So the reds are where you want to focus your time as a mammographer. And that's the kind of guidance we wanted to help people. Finally, we wondered, could we find cancers earlier with this? And what would give us evidence of that in this kind of study? Well, ideally, what you do is during that year when you're following up, you will find some cancers that were missed by the doctors or by the AI. Well, are those going to show up a year later in the red category or the orange category? Because the AI doesn't make the decision to recall. The patient or the doctor makes the decision about that patient. And so if it looks red, the doctor can say, you know what, I'm not going to recall it. Many of those cases, not many, some of those cases show up a year later as abnormal. And this, you can see in the data, is a lot of those are these high red and orange categories. So very compelling that we should be able to do better as mammographers. One more piece of scientific evidence, we published this study in Nature Medicine in a much smaller reader study. The dots are the green arrows are pointing to 5 individuals. The ROC curve in red is the AI. And again, the AI outperformed the physicians and also in finding the cancers earlier. Finally, I want to close by talking a little bit about a new workflow that is at the heart of EBCD, and that is an enhanced review. We've been calling this accord because we're looking for accordance or concordance between different physicians. The way this works is there's actually 3 reviews in EBCD. There's an initial read by the physician who gets the AI. Second, we've dichotomized the output of the AI to basically say, is this a positive case is it a red case that we're really nervous about or not? And if there's a mismatch, if reader 1 says this is a BI-RADS 1 or 2, yet the AI thinks it's a red case, then it goes to a third reader, a second human. And this expert looks at both of these. And in the cases where she agrees with the AI, she picks up the phone and calls reader 1, and they decide to modify the report before it goes out. So there's no report issued. It gets put on hold when there's this mismatch. So there's no confusion on the patient's part that there was a change. It's just an enhanced review process. And this has been spectacular. Also, at the Society of Breast Imaging meeting, we presented data showing that the cancer detection rate went from 5 to 6, 5.3 to 6.5 specifically. This was 41 additional cancers across 40,000 mammograms at one site in Delaware. Very impressive statistical improvement. And again, this was prospectively done. And while there were 228 cancers found regular way, because we knew when we were flipping due to this enhanced review, we knew we found 41 additional cancers. There was a small increase in the recall rate, but not much, very much worth that trade-off. And we've now rolled this out across those 148 plus sites, and we've found hundreds of extra cancers by having this. And this is what has led to ebcd. The Enhanced Breast Cancer Detection Program, when a woman enrolls in that, she signs up, she pays the added fee because there's no insurance coverage for this, and it goes, the AI then is given to the first reader, there's a second reader involved, and now this third reader in the cases where there's a mismatch. So every reader gets every woman gets two looks, the first reader and the AI, and in the important cases where there's a high suspicion, there's a third reader brought in. Here's kind of the outlay of what we ask the patients to understand, and there's really just these steps. The AI goes on the mammogram. It helps the initial radiologist. There's a second set of review by the AI. And then finally, if needed, an additional radiologist brought in. And this little placemat that I've shown here is what we show the patients when they come to check in, just so they understand what they're getting into. It's been very seamless. We've had literally tens of thousands of patients sign up for this. And we've had a lot of really positive responses. I just will finish by saying there's a lot more AI to come. We're working on all kinds of cool things. We have an FDA cleared density product. We've got a workflow sorting product for radiologists, other things that we're very excited about. So happy to answer more questions about AI, but what I'd like to do now is turn the time over to Dr. Holt, who's going to give you some more specific clinical experience with the AI. Take it away, Dr. Holt.
Okay, thank you for coming, and thank you for paying attention and listening to this. This has been really exciting work for us. So I just want to go over the current state of breast cancer screening, kind of take a bird's eye view. Next slide, please. Of just where we've come with breast cancer screening and what this is all about. So there has definitely been success in mammographic screening. There have been technologies emerging along the way, including tomosynthesis, MRI, and now artificial intelligence. Go ahead. So our enhanced breast cancer detection incorporates both the AI component and also that second reading, or that concordance or accord process. And it's been very effective at finding additional cancers. We've been doing this for a while, and I am a total believer, and I'll show you why. So our goal, what's our goal in breast cancer screening? We want to find cancer smaller, because that decreases the mortality, it decreases the surgery, the morbidity, and the type of surgeries that have to be performed, less aggressive, and a lot of times less chemotherapy if you can find something at a very early stage. So really the why we're doing it is because we want to find cancers at their absolute smallest that is possible. And if you're in stage 1 and even stage 2, very high survival rates with breast cancer. So as a reminder, the mammography is the only imaging modality that has undergone the rigors of randomized control trials. And these randomized control trials can never be repeated because they were so efficacious. We can't say in this day and age, you are invited to screen and this other group is not. I just wanted to point out the Tabar is on almost all of these. He's really, next slide, the grandfather of the screening mammography and of these trials. And most of them were done in Europe, and he's in Sweden. I'll come back to him in a minute. But there was at least a 25% reduction in mortality. And as I said, these were done in the 70s, 80s. So some of these were done with a one-view mammogram. It was older equipment. Most importantly, these women were invited to screen. If that letter was in their mailbox, even if they didn't show up, they were counted in. So when you look at the SEER data from those who actually were screened, there is a higher reduction in mortality of those that were actually screened. I don't think that's a surprise. But also, when you look at the data over time, breast cancer mammography really started, in this country in full force, somewhat 90s. And you can see sort of an analogous 42% decrease in mortality. Of course, this is a combination. You see the cancer, therefore you treat the cancer. So we've done pretty well. Now, this is a look back, and you can see sort of what we were dealing with the screen film. It was very shades of gray. Then we get into digital and things become sharper. Go ahead, Greg, next slide. And breast tomosynthesis entered in 2011, and that is really what we call the 3D mammogram, and the gantry rotates at 15-degree intervals and gives us sort of a 3D image. And what that means, the breast is made up of fat and glandular tissue. The glandular tissue would be like those blue circles, and they could hide. A cancer actually does in some ways look like a star. It has these spicules coming out. And if you can pull out of that 2D, and this runs sort of like a cine in real view, but you can see a separate slice. And so this helped us. It also decreased our recall rates and helped us find more aggressive cancers, especially the invasives. Okay, so vascular imaging is one way, is breast MRI. And what breast MRI, this is a real image on the next slide of why vascular imaging can have an advantage. You can have dense breast tissue, and you know that there's a cancer in there. It lights up on MRI in that left breast. And this woman looks like she's laying prone, but actually, I mean, it looks like she's in compression, but it's because she's prone that the breast looked that way. But a cancer was hiding in there. And MRI works on the principle of tumor angiogenesis. The vessels are recruited into the tumor, and then it enhances. The problem with MRI, and even abbreviated MRI, is that there aren't enough MRI scanners on the planet to perform screening on every woman. And there is also an injection of gadolinium involved, although I think it's a very good test, especially for the high risk. That's considered greater than 20% lifetime risk. So a lot has changed. I am actually carrying in my pocket 1 million times more storage than we had in the 1970s and 80s. And likewise, AI was developed. Dr. Sorensen, I met him many years ago, and we were very excited about the possibility. And we did have in Delaware an AI-driven review process. And how that worked is that if the first screener, the first radiologist, read it as normal, I'm sorry, if the first screener, BI-RADS 1 or 2 is normal. If they read it, this is not normal, the report was released because the radiologist wanted callback, so that went out. If it was AI suspicious for cancer, if there was a disagreement, if the radiologist first reader initially read it as normal BI-RADS 1 or 2, AI found it suspicious. This is a discordance, and that went on to discussion and a potential callback. A lot of times, the human and the AI were all in agreement. The humans, two humans, were in agreement. So this was only intervention if there was a discordance in this process. And this is the way we actually found out that AI can find these cancers that humans somehow miss. We have blind spots. I think it's the AI can have all its little eyes on every little part of the image, whereas humans can't have blind spots. So this is a dense breast, and this was passed as a BI-RADS 1. The AI put a box and said, look there. So this went to a second review, and the second reviewer said, yes, I think that there could be a cancer in that back part of the breast. And on the diagnostic images and subsequent ultrasound and subsequent biopsy, this was an invasive ductal carcinoma with perineural invasion. So that was in the back part of the breast, but actually we have a blind spot as mammographers, breast imagers in the front part of the breast, because we're used to seeing a lot of tissue right behind the nipple, and it can look a little bit spiculated back there. But this, the AI tagged it as, no, this is highly suspicious. So this went for a second review, and this was an invasive ductal carcinoma that was found in a potential blind spot that the radiologist didn't see. Now, also we call them busy breast. There's nodules all over. Most of them are benign. Usually when you talk about multiplicity, you're talking benign disease such as fibroadenomas or cyst. But you can see how this is a difficult mammogram, and you could choose to focus on, with like that blue arrow, one of the nodules in the back, and you can get hung up on chasing that down for 10 years prior and seeing if it was there. But the AI said, no, this is the most suspicious right here. And as soon as you look at that, it almost looks like that star that you saw. And that is a cancer. And you blow it up, and then you call it back and you do a biopsy. And this was an IDC that also had associated ductal carcinoma in situ. So we also have blind spots in subtle lesions. This is a lobular cancer. It's very hard to perceive. The AI, it was passed, but the AI said, look closer at that. And with this Accord second review, that second radiologist has a chance to really hone in on just that. And there are the most subtle spicules coming out of that area of the glandular tissue. And next slide, lobular cancers are very sneaky like this. They grow along the tissue. This is the callback, looks a little bit more spiculated, if you will. So that was an invasive lobular carcinoma, and I believe an early find. I put this in here because AI does very good with calcifications too. These calcifications that it tagged with the arrow really look a lot like the classic benign calcifications. This went for biopsy of both the areas. It was passed initially by the radiologist. Second review said, yeah, why don't you magnify that? It was magnified. Both areas were biopsied. The AI initial found calcifications were DCIS, high grade. So next slide. Then in 2001, there was FDA clearance for our SAGE DX. And we did start to use that, but we still thought that there would be a value in this Accord process, even though the radiologist is cued in with boxes with the AI. And what we found is that we were still finding cancers. They were just subtler. So developing asymmetries, this is written about in radiology literature, very hard to perceive subtle changes on the mammogram. And this was second read, even though the radiologist could see the box on it, and this was second read as a poorly differentiated IDC, and it had lymphatic invasion, and it's good that we found it that year and not the year following, let's say. So this is also very subtle to me. It's just a smudge at the back part of the breast. And when you put that together with a second reader who's really just honing in and focusing on that, you would call that potentially something that needs another look. And that was just an asymmetry, really. That was an invasive lobular carcinoma. And again, I'm glad that came out this year. So this is my colleague, Dr. Maria O'Hara, myself, and under Greg Sorensen, Dr. Sorensen and his team from Deep Health. We did present this just a couple weeks ago at the SBI, and this is a summary of that data, really using this Accord process. Go ahead, next slide, please. And just knowing that humans, we're not 100%. There will always be a non-zero value where we will miss a cancer. So can we improve that, improve our cancer detection using an AI-driven process? And this is our Accord process. We had in Delaware 40,000 screens, and we did call back about 3,000 of those, which is a very acceptable recall rate. We found 41 extra cancers with just a subtle bump in our recall rate. So it was a very effective recall. And we increased our cancer detection rate from 5.3 to almost 6.5. We are 6 radiologists, and every one of us did benefit. This is a chart, next slide, of our cancer detection rates. All 6 radiologists, labeled 1 through 6. We were all helped, some more than others. And as a group, we have a cancer detection rate, which is really well above national norms, which would be considered 5 or sometimes 4 or 5. So we're up at 6 as a group. So it's a really excellent quality assurance program, as well as finding these cancers earlier for these women. So in conclusion, we found 15% more cancers utilizing, harnessing the AI along with the human EBCD review. And just to make this personal, this is a patient from Delaware. The circle you see is around a mole. I know, see, these things get distracting, but the AI tagged a little thing in front of it, and that was an invasive duct carcinoma. You can go to the next slide, grade 2. One more slide, and then the point I'm going to make is this is dense breast. AI looked at it. It was initially passed. We had that second review process. That was the TOMO. Go ahead, next slide, next slide. And so the TOMO showed it. And this is, she was treated, breast surgeon in Delaware, and she's post-lumpectomy in 2022. She had XRT, but no chemotherapy. And really, it's very difficult to explain this process, because all the breast surgeon knows is that we found a subtle cancer. All the patient knows is that we found a cancer. They don't really realize, and that's why it's a hard explanation, that every cancer that is potentially seeable on that mammogram, we've worked hard to find with both the human and the artificial intelligence. Next slide. This is actually very unique to our practice. We do about 1.5 million mammograms as a whole, RadNet does, which is about 5% of the mammograms in the country. But in the New York Times just a couple months ago, and this is a group out of Hungary, and really we're doing the same kind of program here in the United States that was published in the New York Times. And this doctor says, AI saw something that seemed to just pop out of nowhere. I hope that I convinced you that some of these look like they just pop out of nowhere. And our grandfather of mammography, Laszlo Tabar, says, I'm dreaming about a day when women are going to a breast cancer center or an imaging center, and they say, do you have AI or not? Thank you. I will turn this over to Dr. Renee Quarterman, breast surgeon and director of Delaware Breast Care.
Hopefully now you can hear.
Yeah,
Okay.
you're good.
Thank you, Dr. Holt. Good evening, everyone. So my part of this presentation is really to give you a sense of what I, as a provider, see as the power of AI now, and what we as providers can do today for our patients. Next slide, please. So this is a post on breast360.org, which is a patient-centered website that we breast surgeons use to educate our patients. And this was a post that I actually put up in 2020. There was an article from Nature magazine that was talking about artificial intelligence in breast cancer screening. And so we as breast surgeons have been very excited about this modality and really waiting for it to be available for our patients. And I'm, for one, very happy that it's here. Next slide, please. So looking at this modality, I think about whom does it help now? And I think it's important to ask this question because, as Dr. Sorensen said, this is not something at this point that is covered by insurance. And so not every patient is going to be in a position to do this. So it can help us to just differentiate and guide what patients in our practice should really make the effort to have this extra beneficial screening addition. You can go back there, please. So I think about patients with an average breast cancer risk. I think there's a role for AI for them. Women who were diagnosed with breast cancer under age 50, I think there's a role. And then finally, patients who are at increased breast cancer risk, either higher than average but under 20% lifetime or 20% or greater lifetime risk. Okay. So first, thinking about the patients with average breast cancer risk. The Mammography Quality and Standards Act, I think it's important to keep this in mind. This was created by the FDA in the early 90s, and it is established to regulate how mammography facilities and the providers who perform mammograms actually deliver their care. There is a maintenance of accreditation. There is an annual inspection. Each facility has to be accredited by the American College of Radiology, as do each of the providers within the facility. One of the standards is that each patient that gets a screening mammogram has to be provided with a written report in an understandable language within 30 days. And because of all of the standards and all of the details that these facilities and providers have to pay attention to, our patients are getting better breast cancer screening, they're getting better care, and facilities are providing better breast imaging services. One person that I think really improved all of this was Dr. Nancy Capello. So she was a woman who palpated a mass in her breast after her screening mammograms told her that everything was normal. She went back for diagnostic mammograms and ultrasound, and the diagnostic mammograms were also normal, but the ultrasound found a mass that ended up being cancer. She did succumb to her disease, but not before she made an effort to make people aware of breast density. So she didn't know that her breasts were dense on mammography, and she didn't realize that that density prevented the breast cancer from being seen at an earlier stage. So she and her group have been very successful in really spreading the word among all women who are candidates for screening mammography to think about their breast density and to ask about it. And they've gone a step further, as you can see by that map that was updated earlier this year. Pretty much every state in the country, that every mammogram facility in each state has to report to those patients the density of their breasts and emphasize that the density can affect the detection rate of cancer. So the FDA, again, following the MQSA, they have updated their regulations for each mammography facility now, that each facility has to provide information about breast density. And you would think, I think a lot of us here are used to seeing this information in our patients' reports, but that's not the case for every patient in the country. So as of September 2024, every facility must inform each patient about the density of their breasts on screening mammogram. So the quality is increasing, and I think the awareness is increasing. Next slide. So I get this a lot, and I'm thinking that you as providers also do. Patients will come into my office with their written report from the mammogram facility saying, I'm nervous. What does this mean? 10 to 15% of breast cancers are not detected by mammogram. My breast tissue is dense. Dense tissue is common but not abnormal, but it can make it harder to find cancer on a mammogram. It's hard for me to provide reassurance to my patients who are at average breast cancer risk that their screening mammograms are fine. It's hard to get insurance to cover additional imaging when women are anxious, and I'm anxious, but that's it. We don't have any numbers to justify additional imaging. Next slide. So I believe this is a situation where enhanced breast cancer detection can really come into play. If our patients are in a position to do so and they can get this modality, it can really reassure us and our patients that abnormalities on mammogram were not missed. So I think it's important for our average risk patients who have dense breasts or who have a family history of breast cancer or who are just flat out anxious about mammogram missing cancers that they pursue enhanced breast cancer detection. So the next group, or the next two groups, really are ladies who, for whatever reason, will qualify for screening MRI. Dr. Holt has given a great overview about the value of breast MRI. As a breast surgeon, I use them, I seek them out, I need them quite frequently. However, they do open up a can of worms for a lot of my patients, leading to more imaging, biopsies for things that end up being benign. Sometimes they can delay cancer treatment as we work all of this up. So one group that we consider breast MRI in, next slide please, are women who have been diagnosed with breast cancer at a young age, under age 50. So the American Society of Breast Surgeons, they have in their list of recommendations for screening on the very bottom of this slide, women with a prior history of breast cancer under age 50. It is recommended that they have annual mammography as well as access to supplemental imaging, which would be breast MRI. So we would recommend for this group of ladies that they have screening every 6 months, alternating mammogram with MRI. The American College of Radiology also has updated their recommendations for screening, and they include women diagnosed with breast cancer under 50 as having annual supplemental breast MRI as well. Now, there are certainly drawbacks to breast MRI. It's expensive. I have my patients talk to me about this all the time, and I suspect you as providers do as well. Even if there's a deductible, sometimes they have to pay the entire deductible before their MRI is covered. Insurance may not authorize MRI. Comfort is another issue. So the positioning is difficult. Dr. Holt showed you that picture. A lot of my patients complain that there's pressure on the xiphoid process. That bench is not a couch. It is hard. It has to be. The magnet is small and tight. You can't move. It's loud. It takes a long time. So it's not easy to get a breast MRI. The advantage is that it is highly sensitive. The specificity is increasing all the time, but there's still that concern about the false positives that we have to deal with. Next slide. The other group that qualifies for consideration of breast MRI would be our patients at increased breast cancer risk. And the cutoff for the value that we consider significant is 20%. So you can go to that next slide. If a woman's breast cancer risk is 20% or greater because of family history of breast cancer, personal history of biopsies, or personal hormone exposure history, maybe she has a pathogenic variant, those women qualify for risk-reducing medication, endocrine therapy, and they also qualify for enhanced screening because of an increased rate of interval cancers, which is a cancer that happens in between your annual screening mammogram. So we want to offer these women imaging every 6 months. And again, the American Society of Breast Surgeons has said for women with a lifetime risk of greater than 20%, annual mammography as well as supplemental imaging with MRI should be offered. And the American College of Radiology has also said the same thing. And that's that top bullet point there. Calculated lifetime risk of 20% or more, adding MRI to their screening should be considered. But again, for this same group, the drawbacks are still the same. And I would say that personally, I have had increasing pushback and denial from insurance companies for ordering MRIs for any patient whose lifetime risk for breast cancer is under 20%. So if it's 19% and it's documented, if she has a history of breast cancer before age 50, despite the guidelines from national organizations, MRI is not covered, and my ladies are not getting MRI. Certainly the comfort, sensitivity, and specificity remain concerns. So in these groups, you have to think about, or I think about, other things that can be offered. And I think this is a great opportunity for enhanced breast cancer detection. This is one group of women where I think it could be beneficial. Next slide, please. So certainly, I don't think you can say that enhanced breast cancer detection can replace MRI. It certainly can't. It's apples and oranges. As Dr. Holt has said, MRI is more of a functional imaging study. However, again, there are groups where it could be more beneficial. So if you're thinking about enhanced breast cancer detection versus MRI, enhanced breast cancer detection can cause less anxiety. Women can be more comfortable with it. It's certainly a faster study, and it's less expensive. So in my opinion, at this point, enhanced breast cancer detection will allow for earlier detection of breast cancer. And this is what Dr. Holt has demonstrated. We know that lobular subtypes of cancer are more difficult to see. And so it is my hope that AI will help facilitate finding these cancers earlier so that women's outcomes are better. Certainly, finding a cancer earlier will help us de-escalate treatment. Instead of mastectomy, lumpectomy. Doing a smaller lumpectomy, removing less tissue. In some women, we may be able to omit lymph node sampling. In some women, we may be able to do less radiation or omit radiation altogether. And certainly omission of chemotherapy is possible the earlier you find the disease. And all that leads to improved outcomes. Next slide, please. I also think that enhanced breast cancer detection will alleviate anxiety in general for our patients about missing a cancer in general. Some of my patients who don't have dense tissue still come in questioning if mammogram is enough. I think that adding AI to their screening is perfect for them. Certainly not being able to see through dense breast tissue, patients are concerned about this all of the time. And when our patients cannot or will not get MRI, I think that enhanced breast cancer detection is a comfortable and affordable alternative. Next slide. So right now, how am I using enhanced breast cancer detection? First of all, I'm suggesting that all of my Black patients consider getting enhanced breast cancer detection with their screening MRI. You might have read recently that the USPTF updated their screening recommendations. For years, they were saying that every woman should start screening at age 50 and get screened every 2 years. They were one of the few bodies that made those recommendations. Most organizations did not agree with that. They have since, maybe the past 2 weeks or so, changed that and dropped their screening age back down to 40. But before they did that, they noted that Black women had worse outcomes with breast cancer, stage for stage, class for class. And so they recommended that these women get screened for breast cancer earlier than the average, than the rest of the group that was at average risk. So I think that it's important to keep that in mind. And I recommend it for Black women for those reasons. Again, patients with dense breasts, we've seen how well that it works for them. So even if my ladies are average risk, I recommend that they consider getting enhanced breast cancer detection if they can. Other groups where it's useful, women who have a high risk for breast cancer, whether it be greater than 20% or just higher than average. Certainly women who are diagnosed with breast cancer under age 50, and also women whose cancers were diagnosed on MRI. There are some women where breast cancer is not seen on mammogram, and hopefully if insurance does not cover MRI for them, then we can use enhanced breast cancer detection with some comfort there. And certainly all of our patients with any anxiety about the efficacy of screening mammography should be offered enhanced breast cancer detection. And thank you very much.
Thank you guys so much. Great presentation. We did get several questions, so I am going to read those off, and hopefully we can get through as many as possible. If we can't complete all the questions, then we'll make sure we follow up with each individual to make sure all of your questions are answered. Okay, so the first question I have came through is for Dr. Sorensen. If a woman has a BI-RADS 4 or 5 on her first read, can her $75 be refunded?
So short answer is no. And the reason is that the whole process and the $75 enrollment fee includes the SAGE-DX tool on that initial mammogram. And remember that many patients have 2 lesions, sometimes in contralateral breast, sometimes in the ipsilateral breast. AI is looking everywhere. So even though the doctor sees something initially and might have even seen it without AI, we know that many doctors do a great job without AI. It just makes them even better. It's that added boost that both in confidence and in both in sensitivity and specificity, as well as the confidence. So we feel that it makes sense to give all of that, and that's all happened as part of that initial read. So that's why we do refund if the AI can't run. So if the AI fails because of some technical problem, maybe the computer wasn't working or there's something technically rejected by the system for that mammogram, then we do refund the $75.
I have another question for Greg, or Dr. Sorensen rather. What was the data set, for example, the demographic group given to the AI during its training process?
So we initially trained it on about 8,000 patients from the United States and from Great Britain. We've been fortunate since becoming part of RadNet to further have access to the very diverse racial and socioeconomic range of patients that RadNet sees. And in fact, in our submission to the FDA, we essentially took a random sample and they told us there were too many Black women in the study that we had tested this on. So we've worked hard to bring a broad range of training data into SAGE-DX. And we know now that the performance is very strong in both dense breast tissue and in women of all races. So very important question. And that's why I wanted to show you that that broad range of performance data over 500,000 women.
Okay, so the next question I have is for Dr. Holt. How has the use of this AI technology changed the way you read on a daily basis?
Well, it using the AI makes me more efficient because it shows me exactly what I should be focusing on, and also what I shouldn't be focusing on. I kind of say AI can have its eyes on all things, and I feel that if it has gone through the AI process and those boxes, I want to spend the most time on the most suspicious mammograms. And I think that we are finding more cancers, even just utilizing this tool. Even if we really have become almost hyper expert using it along with our daily reading.
Thank you, Dr. Holt. Okay, so our next question is actually for Dr. Quarterman. How do you explain the benefits of the AI technology to your patients in a way they understand?
So I keep it very simple, and I say, you know what artificial intelligence is? They say yes. And I say, okay, well, what happens is the radiologist will read your mammogram and AI will read it as well. And if AI finds something that the radiologist didn't see, then another radiologist will review it as well and talk with the first radiologist about it. And they seem to get that, or simplify it and just say, well, AI just comes after the radiologist. But I do emphasize that the radiologist does read it, and it's not a robot in a room just reading a mammogram. I don't want them to think that at all.
Can I add that report is actually held on our side until that second opinion is rendered. So it doesn't go out until it's complete, and all three sets of eyes, if you will, the first radiologist, the AI, and if necessary, the second expert. And then that comes out as one report. It doesn't confuse the patient.
Thank you both. I have another question. This is going to be for Dr. Sorensen. Does the mammogram report state that AI was utilized if the patient did enroll in EBCD?
The mammogram doesn't report, the mammogram report does not say anything about the use of AI or not, other than it does say that, well, I shouldn't say that. The mammogram does have a line in it that says that AI was used when it is used, yes. The whole process about the multiple readers, we feel like that's too complicated to explain. Just like a mammography reports used to say computer-aided detection software was used, our reports now say artificial intelligence was applied, was activated for this mammogram.
Great. A couple more questions coming through. Let's see. Does the is AI an extra screening charge?
No, what the extra charge is not for the AI on the first interpretation. That's already bundled in by the nature of the CPT code that includes a mammogram. That a screening mammogram includes computer-aided detection software already. So the extra charge, the EBC enrollment, is really for that second and third set of eyes, if you will. That's why, and that's extra work, and both the software was extra work to create and also that extra human, and that's hence the need for the extra charge.
Okay, another question. If a patient has dense breast tissue and pays for the AI, should she still have a breast ultrasound?
That's up to Dr. Holt, right? It really depends on the clinical situation, right, Jackie? Yes. If you have an MRI, you don't need an ultrasound. But if you have a mammo and you want additional screening, I mean, this gets into like complicated. Most patients only have ultrasound if they have a symptom in Delaware. However, in New York, they do a lot of ultrasounds screening. So it's all independent. It's all independent. And dense breast tissue still obscures even with AI.
Okay, I'm going to ask 2 more questions just to try to be respectful of everyone's time. The next question, will AI reduce the number of callbacks?
Yes, is the short answer. We do believe that the increased sensitivity does not necessarily, what we saw in our reader data study was that we saw increased sensitivity, so higher cancer detection rate, but we also saw increased specificity. And part of the goal of EBCD is to both increase cancer detection, but to actively lower the recall rate. So those are, that is the magic coupling we are hoping for with AI, is that while it's easy to describe and confirm the fear of breast cancer, and so yes, everybody wants to find more cancers, we also recognize, as the USPSTF has acknowledged again, that there are downsides to recalls. And if we can reduce those recalls while keeping the cancer detection rate high, that's really the promise of AI. And I would just finally say, we haven't really talked about this, but the goal of EBCD being a self-pay thing today, where we charge the patients, is really meant to be a bridge to the future, where insurance companies recognize the value proposition of this. And like with 3D mammo, where they didn't pay for a long time, and then once there was enough essentially momentum behind it, because women were paying out of pocket, they decided to cover it. And part of the reason we believe they will decide to cover it is because it will reduce recall rates as well as boost the cancer detection rates, and therefore save the payers money right away. So this EBCD self-charge thing, I hope, is just a year or 2 of a transition period until the payers recognize the data we're collecting and start offering it as part of standard insurance coverage.
Thank you. And the last question, can AI be applied to an image done at another facility?
Not right now. Today, we bundled this in to this package. In theory, any facility could acquire the SageDX technology and apply it either at the time or in hindsight. We don't have a simple mechanism for that. I would say if you're listening to this and your mother has a mammogram and she needs something, send me an email. Like, I'm happy to respond to one-offs, but we don't have a system for, for kind of how to handle that routinely. But I'm very sympathetic. My wife, my mom, they're like, okay, I would say my boss's wife, okay, I want my AI I want you to run the AI on my mammogram. We'll find a way to do it. But in general, that's not the structure of the EBCD program.
Thank you. Okay, so that does conclude our 1-hour EBCD presentation. Just another reminder for those that may have not been able to join right at the start. Attendees will receive an email with instructions on how to pull your CME credit within a day or 2. And you may also reach out to any of your sales reps with questions, especially if your questions went unanswered at the end of this presentation. Thank you again. Thank you to our presenters, and have a great evening.
I would just answer one last question that I saw coming through the chat. People wondered about younger women. SageDX is approved from age 35 and up for screening mammograms. So thanks, everybody.
Thank you, Dr. Swanson. Thank you.
Thank you. Good night.
Thank you. Good night.